We're so honored to have Antonio Ciaccia, president of 3X Access Advisors and CEO of 46 Brooklyn Research, joining us today to really uncover the underbelly of PBM tactics behind the scenes, and to also debrief us on the Inflation Reduction Act and discuss the remaining drug pricing issues that currently need to be addressed as an opportunity moving forward. But a little bit about Antonio. Antonio was born, raised in pharmacy. He has been crawling around pharmacies his entire life. After 3 years as a pharmacy technician and 2 years of pre-pharmacy curriculum, he diverted his course and graduated with dual degrees in both communications and political science. Thinking that pharmacy would be in his rearview mirror, he ended up making his way back to this pharmacy home and headed up the government affairs at the Ohio Pharmacists Association, a trade organization with a strong track record of advocating for drug pricing transparency. Antonio became increasingly perplexed and concerned as he saw that drug costs were skyrocketing and getting out of control, while the payouts to the pharmacies were declining to the point of unsustainability. Antonio spent years working to crack the drug pricing code and pull the rug out from what he believes is one of the most dysfunctional marketplaces in the world. He is obsessive about the prescription drug supply chain and the pharmacy policy. So in that regard, Antonio, what are we missing about the new Inflation Reduction Act that could have unintended consequences and is not obvious to us organizations, our physician groups, our pharmacists, and legislators today?
Thanks a lot, Karen. Great to be with you all today. I think we should start by kind of framing up, who PBMs are, what they've become, and who they're going to be in the future, and then tie that back to some of the discussion around some of the current policy initiatives that have been proposed at the federal and state level, and then talk about perhaps some of the things that should not have been left on the cutting room floor. So PBMs were architected back in the 60s when, in the old days, when patients used to come in to the pharmacy in order to receive coverage from their health insurance company, what health insurers used to do is work on behalf of employers to cover meds for a very, very small segment of population. What they did is we used to call this the shoebox method. This predates me. Don't let my bald head fool you. I'm not too old yet. But way back when, what they used to do is, if I was a patient and I had the medications covered, what happened is the pharmacy would give me a receipt and I would keep them in my shoebox, and then I would send them off to my health plan intermittently, and then all of a sudden, my employer would get dinged for them, and then myself as the patient would get compensated from that. Well, that created a lot of unpredictability for the employer because they would never know, like, okay, how many bills are going to come due. So they sought ways to make it a little bit more real time. And PBMs were brought in to act as, we'll just say, is a more real-time transaction, almost like a Visa or MasterCard for your prescription drugs. Well, as drug costs got more and more expensive, as more and more medicines came to market, and as we as consumers demanded more and more coverage for our medicines, so too did the PBM role change. That the plan sponsors, the employers, and the patients look to PBMs to not just simply pay the bill, but to start influencing the bill. To say, okay, rather than just paying whatever anybody bills us, let's ensure that we are providing a negotiation to try to achieve a fair price. Let's not cover every drug. Let's not pay whatever price the pharmacies and or drug makers want to charge. And so have that start to work to provide a balance, if you will, between enabling access to medications, but to also not have to overpay for those medicines. Sounds great, right? Well, over time, that started to change. PBM started to, what I like to say is, taste the forbidden fruit. They were supposed to work to control the prices of medicines, but then started to develop conflicts of interest where they started making money off the prices of medicines. And so a lot of the old games that one end of the supply chain was playing in the past, PBM stepped in and said, we can play those games too. And so it started to kind of spiral out of control. Not to say that PBMs became double agents, but the degree with which they live between, let's say, a more fiduciary-like role relative to somebody who was working as a double agent, it just started to shift more and more. PBMs were granted an exemption to the federal anti-kickback statute that allowed them to be compensated by drug makers in exchange for covering the medicines on patient formularies. So rather than just working with the plan sponsors or the employers or the patients as their clients, now PBMs were also clients of drug makers and also became clients of pharmacies, and actually became pharmacies when they started architecting their own mail order pharmacies, specialty pharmacies, and in the case of a company like CVS Caremark, their own retail pharmacies. So you can understand where what started off as really, really well-intended a concept, as PBM started to horizontally consolidate more and more, they got more and more powerful, but then their vertical integration conflicts, getting compensated by drug makers, making money off the dispensing of drugs, being able to mark up the cost of medicines, all of a sudden the PBM started to change. And what we saw was that they started to incentivize higher and higher prices within the drug channel, exacerbating the problem that they were brought in to solve. So a lot of the problems with PBMs have been because they're making too much money off of the high prices of the medicines. They're making money downstream at the pharmacy level, being compensated as the dispensers of drugs. And they're able to take advantage of the opacity and the lack of transparency in drug prices to pay very low in some instances and bill very high on other instances. So our experience really started in Ohio, as Karen mentioned, where pharmacists in my home state were complaining to me that PBMs within our managed care program were paying pharmacies at rates that were unsustainable. To give you an idea, in the summer of 2016, pharmacies in my state saw an attrition of margin to the tune of 60 to 80% in just the course of a month. So if you were a pharmacy in a high Medicaid area, obviously, disproportionate, underserved areas, well, those pharmacies saw 60 to 80% of their operating margin wiped away. When I went back to state officials to quiz them to see whether or not I missed a policy change that would account for such a swing, they looked at me like I had worms crawling out of my eyes. They said, Antonio, we have no idea what you're talking about. We're spending more for medicines than we ever have. Those two things don't make sense. How can the providers dispensing the drugs see such substantial cuts, but the state at the other end of the transaction, cutting the checks to the insurance plans and PBMs to pay for those drugs, they're spending more than they ever have. So that set us off on a journey to try to figure out, where's the money going? What can account for this gap? And so we started downloading really boring Excel files off of the Centers for Medicare and Medicaid Services website that gave us some directional insights to the cost of medicines relative to what state Medicaid programs like Ohio were being charged. When you stitch those two data sets together, the real cost of the drugs relative to what Ohio Medicaid was being charged, you saw a growing gap start to emerge, that the state was not getting the benefits of deflating generic prices, but instead those old prices that they were being billed were suspended in animation. They were impervious to the competitive dynamics driving drug costs down. Now, be clear, that wasn't for all drugs. Brand drugs are still going up over time, but the generics exist to offset some of that pressure, and none of that pressure was being offset. That prompted state officials to start their own investigation. The Columbus Dispatch locally started their own reporting inquiry into the matter, and the state decided to crack open the books, much to the PBM's dismay. And what we found was that PBMs were, in fact, paying pharmacies low, billing the state high, and pocketing the difference. The number that was found in that gap was
Uh-oh.
Antonio, I think we lost Antonio at the punchline.
Oh,
I said-
no.
We lost you at the punchline. The number in the gap was, and then you froze.
Okay.
Sorry.
$245 million in just 1 year of our Medicaid managed care program. So what PBMs were doing was paying low, billing high, pocketing the difference in a practice that we typically refer to as spread pricing. But bear in mind, this is just but one way that PBMs are compensated. As I mentioned at the onset, they get paid off by drug makers in exchange for covering certain drugs. They own their own pharmacies where they can set the markups and pay their own affiliate pharmacies different rates for dispensing products. So we're talking about $245 million in just one line item in the PBM Excel sheet, right? So there's your hint that, again, perhaps these cost-cutting middlemen are effective at lowering costs for themselves, but quite effective at passing on a much higher rate to those paying the tab. So that started a larger inquiry, right? More and more states started to investigate and file lawsuits over these spread pricing schemes. What we learned after our state banned the practice, they said, PBMs, you can't do that anymore. You can't take that $245 million gap and pass the bill on to us as taxpayers. Well, after that, we found PBMs changing the way that they were harvesting the crops. So after the state said no more spread pricing, all of a sudden pharmacies started getting paid more and more on the medicines. The state never saw the savings after they banned the practice. What happened was PBMs just started overpaying the pharmacies relative to their contract guarantees and clawing the money back a year later and never disclosing back to the state that they had done so. So they went from paying low, billing high, and pocketing the difference to paying high, billing high, and then clawing back the excess later and then harvesting it on the back end. There's a lot of other ways that PBMs can make money, but as you might imagine, these things are not healthcare, right? This is financial engineering. This is taking advantage of the opacity and lack of transparency in the system to game financial gains. So when we look at ways to save money on our overall line item of prescription drugs, it's not to say that PBMs don't have a role. I think I articulated here at the front end that the role of PBMs, the functionality of PBMs can be quite vital and a great accountability for the system. However, the degree with which they're making problems worse, the degree with which they're able to print their own money, now that's a totally different story, because at that point they become the firefighter of prescription drug prices while at the same time being the arsonist of high prescription drug prices. So where does that leave us? Well, more and more states are investigating. More and more states are filing lawsuits. Our firm is in active, involved as subject matter experts with a number of state attorneys generals and Medicaid fraud control units that are investigating and filing litigation in the space. Of more newsy relevance, the Medicaid managed care plan Centene just this week actually settled with the state of Texas for alleged fraud, waste, and abuse issues related to this spread pricing scheme that started in Ohio and then extrapolated to other states. This is just one PBM and managed care plan. They settled in the state of Texas for $165 million this past week, the largest settlement with a Medicaid plan in the history of state government. So this is the reckoning is really kind of a recent thing, and there's a lot more accountability to come. The question is, how is policy keeping up with the realities of what we're learning through the investigation process and the realities of what we're learning through the litigation process. That brings us to the Inflation Reduction Act. One of the things that I find as one of the best things about the policy is there is an acknowledgement that our drug pricing system has run out of control. Insulin, as a great example, you have a vial of Lantus, which last year had a list price of around $285, a single vial. The question, though, is what is the net price the drug maker is bringing in? As I mentioned at the beginning, PBMs and drug makers have secured an exemption to the federal anti-kickback statute. That allows drug makers to compensate PBMs in exchange for covering their medicines. So the question then is, we know the price the drug maker is charging up top, but how much money are they giving up on the back end in exchange for covering the product? Well, we know, thanks to, again, more public investigation, this coming from the Senate Finance investigation in insulin prices, that a vial of Lantus is really at a net price around $35, $40. So the drug maker is charging around $285, but they're only bringing in around $40 for that same vial of insulin. I say this not to, throw the blame out for the drug maker or send it all to the PBM. I say this as a reality that there is around $240 of fluff in every vial of insulin. So the question then is, which price are employers paying? Which price are patients paying at point of sale? And routinely we see that they're getting closer to the $300 range rather than the $50 range. So why is that? Insulin, while it's not what I would consider hyper competitive like a generic marketplace, we have a number of manufacturers that are making insulin products. What do we know about competition in traditional marketplaces? Well, competition is supposed to increase quality and lower prices over time. Because of the exemption to the federal anti-kickback statute, instead we have an upside down version of competition, where competition actually inflates prices because drug makers are following the incentives of the PBM to raise prices higher as a means to increase the concessions or kickbacks back to the PBM in exchange for covering the medicine. It's not to say that if we got rid of rebates, all drug makers would lower their prices to $35 or $40, but we have evidence that that could happen because we see products like Semglee and other authorized generics and biosimilar insulins that are priced in that range. The problem is no insurance companies and PBMs cover those medicines, or at least most of them do not. That's because they're chasing the expensive, overinflated brand price rather than the actual low net cost, low priced generic alternatives. So this dynamic where competition actually inflates prices rather than lowers them has resulted in many patients paying more than they should. Back to the Inflation Reduction Act, one of the great things that it does is it caps the amount of out-of-pocket that seniors pay for a vial of insulin at $35. What it also does is it understands that insulin is not the only overinflated medicine that exists in the marketplace. There are a number of other medicines that are overinflated. And as we all know, seniors who can be very, strapped to a budget, they can't incur these exorbitant overinflated prices. And so the Inflation Reduction Act also caps the annual amount that a senior can pay on medicines at $2,000 a year. So that's great. Now we don't have seniors that have to ration their insulin. Now we don't have seniors that are having to make hard choices. Maybe they're still making hard choices, but certainly not as hard as it used to be when seniors were forced to pay a percentage of list price or all of list price when they're in the early stages of their deductible. So that's something that we could all give a great big round of applause for, right? Well, why did the government have to do that? Why did they have to do that for seniors? Well, this isn't for every drug, but for a lot of these drugs, it's because the prices, again, are overinflated relative to their actual cost. And so great for the seniors, all right, great for the seniors who've been having to make hard choices with their hard-earned dollars or their Social Security dollars as well. But what happens to everybody else? All right. It's great that the administration put a Band-Aid on the problem, but what happens to those who don't have the benefit of the Band-Aid? So you have a majority of patients who are getting their benefits coverage through their employer. They're not afforded these same protections. So there are other people who are uninsured or underinsured. They're not getting the benefits of this. And so we go back to, why do we need these caps in the first place? Well, again, not for every drug, but for many drugs, it's because the list prices are way overinflated to the net amount that the drug maker is end up bringing in. And so the question then is, how do we pop that bubble? And I would argue that's through realigning the incentives and ending the exemption to the federal anti-kickback statute, so that competition amongst drug makers actually can do what it does in other marketplaces, which, as I said, is raise quality and lower prices. But instead, the Inflation Reduction Act not only kicked the can, they crushed the can and threw it in the trash, because the previous administration had proposed repealing that exemption and saying, putting drug makers and PBMs back into the same category as nearly every other marketplace, to say that we're not going to allow kickbacks within the prescription drug supply chain and have them be like everyone else. Instead, Congress punted on implementation. This administration punted it and then finally said, no, they killed the policy altogether. So now we're stuck with these dynamics that overinflate the list prices of medicines. And we gave a gift to seniors to help make sure that they're taken care of, but we've left everybody else dealing with the dysfunctional system that overinflated the prices in the first place. So you could argue from that perspective that the Inflation Reduction Act is somewhat of a mixed bag and a missed opportunity to engage in that fundamental realignment of the market that could have popped the balloon of overinflated drug prices. One of the other things the Inflation Reduction Act did is it also allows for the government to negotiate drug prices with manufacturers. So it's for a select number of medications, certainly will not help all seniors, but it targets some of the more expensive ones that seniors might have to take. Well, look, a drug maker might say, look, negotiation ain't a negotiation, it's a price control. And I think we could argue whether or not that's a price control or a negotiation. I could see glass half full, glass half empty from that perspective. But one of the things that they did is they said, look, negotiation from the government is not allowed with drug makers until a certain period of time passes, when typical patent exclusivity would lapse. Well, what that means is that in 9 years after a brand drug essentially receives exclusivity, that the government can come in and negotiate. They have a different timeline for biosimilar or biologic medications at 13 years. So I want you to think about this from an investor's perspective, all right, or let's say Wall Street's perspective. You have two categories of drugs: typical generic products, which are typically like tablets, capsules, etc. Then you have the biologics, which are administered medications, things that you inject into you, more volatile type substances that require special storage, special handling, and are less prone to replication for competition purposes. One negotiates after 9 years, the other one negotiates after 13 years. So if I'm making an investment into drugs, do I want to go for the one where negotiation is faster or the one where it is not as fast? So we already have a problem where drug makers are calibrating their pipeline into drugs that are harder to replicate because they could help prolong their market share. Well, now the government has created an added incentive in that direction for investments to increase into the pool of drugs that are harder for patients to administer, harder to access, and harder for pharmacies to inventory, and even more so, harder to replicate for generic and biosimilar competition purposes. I hate that. I hate that inequity exists, because what I would prefer is investment in the other category, in drugs that we know are hyper prone to really aggressive competition. So we could argue whether negotiation is appropriate. Drug makers would argue that it hampers their innovation. Consumers and government folks might argue, well, it helps make sure that we get medicines at an affordable rate. I'm not going to weigh in on what's right or wrong. What I'm going to say is the difference between the two has now corrupted what would otherwise be a very efficient market to others. The last thing I'll mention about the Inflation Reduction Act in terms of what it misses, the previous iterations of drug pricing reform that were hatched up by the Senate Finance Committee, the House GOP, HR 3 from Pelosi, also had provisions that would have banned spread pricing in Medicaid programs. That $245 million gap in Ohio that they uncovered, the previous policies would have completely banned that practice in Medicaid programs so that we at the state level and through matching funds at the federal level didn't have to keep subsidizing the overinflated markups that PBMs were slapping on the Medicaid programs. That policy was felt on the cutting room floor of the Inflation Reduction Act. They didn't include it in the final version of the bill, even though it was scored as savings. So I have no idea why they did such a thing. And again, when you go back to, is it good for the government to price control manufacturers or not? If you buy the argument that price controls will hinder innovation, I think we could have legitimate debate whether it does or doesn't. It seems so stupid that we would take risks in that direction when you have savings opportunities already quantified from companies that are just simply engaging in arbitrage or taking advantage of the asymmetry of pricing information without any value associated with what's been invested in it. So it's not to say don't negotiate or do negotiate. It's to say, how is it that we prioritize that over these hidden markups that are providing absolutely no value, no innovation, et cetera, et cetera. So when it comes to the road ahead and what we can do to try and fix some of these things, I argue not for do this, don't do that, but as I said, prioritizing, right? Where is the low-hanging fruit when it comes to examining drug affordability issues, not just in Washington, but across the country? And routinely we see this, what I would just call an overly simplistic view of how to tackle prescription drug costs without an acknowledgement of the fact that it's not simple. This is a really nuanced and complex system, something that isn't as simple as just pressing down at the top. You have to basically start dissecting it from its inside because the core has become so rotten. The PBMs and insurance companies were supposed to work to lower the prices of medicines, but instead they are exacerbating it, which should make us all question the integrity or the integrity of their role as we typically have conceived it in the current system. Making matters even worse, to really bring out, it's early for our Halloween decorations maybe, but I'm going to scare you a little bit. But these same companies that have these conflicts of interest, where they're paid by drug manufacturers, paying themselves at the pharmacy level, if you read the headlines now, they're now buying up physician practices. So they already control which drugs are going to be covered. They can already steer a patient to a particular pharmacy or a particular drug, but now they're buying up physician practices where they can start actually controlling the pen on the prescription pad. So if you thought that they had a value to drug makers before, if you thought drug makers were willing to pay a lot to these companies before because of the control they have over benefits design, imagine what happens when they actually now employ your physician, right? We know this, that United Healthcare is now the largest employer of physicians in the country today. That's an insurance company, not a hospital, not a physician practice. They now essentially own the most number of physicians in the country. And other insurers are following suit. CVS Health just bought Signify just this past month. So I say all of this, yes, I scared you, maybe, but it's not really intended to do so. It's to say, look what we're uncovering on the drug side. And if we can't figure out how to solve for something as simple as a prescription drug transaction, I'll just to give you an idea of it. We know what the drug is. We know the number of pills in the prescription vial. While there's not a lot of transparency in drug prices, we could still directly have an understanding of what the cost of the medicines are that are in the bottle. In addition, we can quantify the value and the cost of the service the pharmacist is providing in dispensing that product. So for all intents and purposes, relative to other segments of healthcare, we're dealing with a transaction that is pretty simple. we should be able to essentially isolate it very well. But think of all the games that we have identified on something that should be essentially so simple. What happens when the same games that are occurring on the drug space start extrapolating in the medical benefit space? What happens if we can't figure out what the cost of a prescription drug should be? Good luck when the same companies that are trying to arbitrage that transaction are also involved in open heart surgeries, knee replacements, and the list goes on and on and on. Think of the hidden markups that occur on a single vial of medicine relative to all the supplies, tools, and staff and resources that go into something as complex as a surgery. If you can't figure out that that's going to be a big problem next, you're crazy. So I appreciate the opportunity to chat with you about this. It's a very complicated industry, and we need more folks like yourselves that are interested in enough, because the second I say PBM to some people, they immediately fall asleep. But we have to know about these things if we're ever going to make sure that we're getting a better value of what we're investing within our healthcare delivery system. And so with that, Karen, I'm happy to answer any questions that anyone has.
Yeah, thank you. One question that I have that is just haunts me, and maybe you can really speak to this, is about the vertical integrations with the insurance companies and the PBMs. I mean, we saw that not that long ago, really, probably 5 years ago? I don't know how many years ago, but that integration is really the what I'm seeing as the controlling mechanism and steering patients all the way down to the administrative burden to these practices, where it's the non-medical switching, and it's the pre-authorizations, and it's the ability to go step therapy, and the formulary control construction that actually has just put patients into not being able to afford these medications and walk away from a pharmacy. All the way to the pharmacist itself, where all the direct fees are being taken out and all of these other fees. And is there any impact that's going to come from this Inflation Reduction Act that is going to also administer other fees now, where these singular insurance and PBMs are going to claw back for an administrative purpose of blah, 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 or controlling all of that we're really going to start seeing that singular integration control happen? What do you think?
So Karen, I think it's a great question. I think that stuff is going to happen organically no matter what. And I can't say whether or not there's something specific in the Inflation Reduction Act that I could point to and say, this is going to exacerbate that problem. One of the things that we do think that the IRA will exacerbate is the issue of launch prices on pharmaceuticals. So the Inflation Reduction Act has a very laissez-faire approach to PBMs and health plans. It has basically left them, off scot-free, and in fact, arguably given them a gift because of the repeal of the rebate rule. One of the things the IRA does is it has increased penalties for drug makers who increase their prices relative to inflation. So whether good or bad, well-intended or not, what happens is that if you tell them, hey, we're gonna penalize you if you increase your prices too much relative to inflation. Well, remember that, we don't engage in across the board price controls in this company or in this country. So what happens is that we've seen drug makers launching drugs at higher and higher prices over the last few years. Scott Gottlieb, former FDA commissioner, went on record when the IRA passed and said, this will make that worse, because if you're telling drug makers they can't raise their prices so much over time, well, then they're going to front load the price more. And essentially, we're going to deal with higher prices out of the gate. But in terms of what this does to vertical integration and its ability to assess fees, I don't think the IRA does anything other than continue to give way too much real estate to PBMs and insurers to continue doing as they've done in the past.
Yeah.
And I think it's worth noting, sorry to interrupt, but 3 companies control 80% of this marketplace, right? And so, if you think about how can they sort of enforce this vertical integration and gobble up other, points of entry to this space, it's because they control the space. They're owning that space, quite literally, for almost everybody.
Totally agree.
And Antonio, what about transparency? I mean, obviously that's exactly what you talk about and what is being hidden from everyone. So the transparency as far as, the base price of NADAC rather than, WAC pricing and all of those kind of things. When you're talking about Medicare being able to negotiate, I don't see a lower of net costs at all. I see just the same old process happening to everyone, and maybe the seniors will get it at the front end, but that's not going to say that the employers are going to get it at the front end at $35 either. So I see nothing changing in the supply change reimbursement, whatever structure. And so no one's looking at the increasing of cost at all. And so
Completely agree, Karen. Look, I say this a lot. Anytime somebody gets the best price, everyone else gets a worse price. And so, years ago, not saying this is right or wrong, but the Medicaid program, they instituted the Medicaid drug rebate program, which required in statute that Medicaid programs get the best price for pharmaceuticals, meaning that, whatever rebates were available, Medicaid would get the biggest ones. Well, Medicaid grew considerably since it was first conceived. In addition, we created the 340B program to make sure that those same discounts could extend to covered entities, federally qualified health centers, children's hospitals, etc. Both Medicaid and the 340B program have exploded since its original inception.
right.
So the question then is, and some economists would argue against this, so I want to be fair, but now that Medicaid and 340B are so large, now that the PBM marketplace has become so hyper concentrated, now that Medicare is now getting the ability to negotiate, the question then is, where does the balloon get squeezed? You've given all these other entities, essentially over half the market at this point, these deals through government policy. What kind of pressure does that create for all the uninsured, underinsured, and commercial plans? And we see this routinely. Again, economists would say, well, look, drug makers, pharmacies, wholesalers, et cetera, their job is to maximize profits everywhere and anywhere, no matter what. And so to say or suppose that they're not already trying to maximize this money in other markets already would be incorrect. However, data suggests that the gap between the best price and what the commercial payers are getting over time, that gap is growing significantly. So I believe that, pragmatically speaking, that as we give more and more people access to statutorily defined price controls or rebate floors, well, now all of a sudden you're creating more pressure to overcharge on everything else. So very much agree that there's a balloon squeezing effect, but between the haves and have-nots.
Yeah, I guess the shareholders of the 3 PBMs are having to look for other ways to squeeze it, right?
The entire drug channel, I think you could argue, think about any business, even outside of the drug space. If you tell them that they have to sell half of their stuff at a really cheap price, the question then is, how does the business keep the lights on?
Right.
All right. Well, they have to start overcharging on other market segments. And it's not to give drug makers a pass or to make them sound villainous in either direction. It's just the reality of business. And the same thing goes for pharmacies, where, pharmacies get underpaid in Medicaid. What happens to everyone else, right? So the problem extrapolates across the healthcare continuum.
But the PBMs do have higher market valuations than the manufacturers. If you want to understand what the market thinks of the PBM's position relative to the manufacturer's position.
Yeah, we do we did an evaluation of PBM stock prices over an extended period of time relative to that of wholesalers and pharmacies and drug manufacturers. And over about a 15-year period, the stock price of pharmacies actually fell to the tune of around 30%. Drug makers went up slightly over that time period, but the stock prices of PBMs and insurers went up like 600% over that time period. It's crazy. You know, as I mentioned at the onset, PBMs were brought in to act as a counterweight to try and get pharmacy prices and drug manufacturer prices under control. Fast forward the tape to today, those top 3 PBMs are Fortune 15 companies, and they are larger than the drug manufacturers and pharmacy companies they were hired to control.
So I want to make sure, see if other